Welcome to Roadmap to Residency's Step 2 Clinical Knowledge Question Walkthrough on Gastrointestinal Bleeding. I'm excited to guide you through high-yield test-taking strategies that will help you tackle these questions with confidence. Remember, this video focuses on how to approach board-style questions, not just memorizing facts. For comprehensive content review, please refer to your favorite Step 2 resources and question banks. Let's dive in. Our learning objectives today focus on what matters most for test day. First, we'll learn to recognize the classic vignette patterns that distinguish upper from lower gastrointestinal bleeding. Second, we'll apply strategic thinking to identify correct resuscitation and management steps. Third, we'll master the timing and indications for endoscopy, which is a frequently tested concept. For the underlying pathophysiology and detailed management algorithms, I encourage you to review the gastrointestinal bleeding chapters in First Aid, your preferred question bank, and other board resources. Here's your core framework for any gastrointestinal bleeding question. The first question you should always ask yourself is this upper or lower? Upper gastrointestinal bleeding originates above the ligament of Treitz and classically presents with hematemesis, coffee ground emesis, or melena. Common causes include peptic ulcer disease, esophageal varices, and Mallory-Weiss tears. Lower gastrointestinal bleeding originates below the ligament of Treitz and presents with hematochezia or maroon stools, think diverticulosis, Angiodysplasia, and colorectal pathology. The second critical question is the patient stable or unstable? This determines your initial management approach. Memorize this framework and apply it to every gastrointestinal bleeding question you encounter. Now let's talk about buzzword associations, which are your best friends on test day. When you see peptic ulcer disease, look for epigastric pain plus nonsteroidal anti-inflammatory drug use or Helicobacter pylori history, combined with melena. For esophageal varices, the classic setup is a patient with known cirrhosis, portal hypertension, and massive hematemesis. For diverticulosis, think elderly patient plus painless hematochezia that stops spontaneously. These patterns appear repeatedly in board questions, so train yourself to recognize them instantly. Let's work through our first case together. A 62-year-old man with osteoarthritis taking daily ibuprofen presents with 3 days of black, tarry stools and epigastric discomfort. His vitals show tachycardia and hypertension, and he appears pale and diaphoretic. The question asks for the most appropriate initial step. Before I reveal the answer, pause and think about what your approach would be. What key features stand out to you? Let's break down this case systematically. First, analyze the clues. Melena tells us this is an upper gastrointestinal bleed. The nonsteroidal anti-inflammatory drug use is a classic risk factor for peptic ulcer disease. Epigastric pain localizes the source. Second, assess hemodynamic status. Tachycardia plus hypertension plus pallor equals hemorrhagic shock. This patient is unstable. Third, apply the test-taking strategy. When a patient is hemodynamically unstable, always choose resuscitation first. The correct answer is intravenous fluid resuscitation with crystalloid. Wrong answers like immediate endoscopy or ordering a computed tomography scan are incorrect because stabilization must always come before diagnostic testing. Here's our second case. A 55-year-old man with alcoholic cirrhosis presents with large volume bright red hematemesis. He is confused with a distended abdomen showing a fluid wave. His vitals show severe tachycardia and hypertension. After initiating fluid resuscitation, the question asks for the next step. This is a classic setup, so think carefully about the specific protocol for this type of bleeding. Let's analyze this case. The combination of cirrhosis plus massive hematemesis equals variceal bleeding until proven otherwise. The ascites and confusion suggest decompensated liver disease with hepatic encephalopathy. Now here's the key test point. Variceal bleeding has a specific management protocol. After resuscitation, you must start Octreotide, which is a vasoconstrictor that reduces portal pressure, and prophylactic antibiotics, typically Ceftriaxone, to prevent spontaneous bacterial peritonitis. The correct answer is to start Octreotide and antibiotics. Endoscopy with band ligation comes next, within 12 to 24 hours once the patient is more stable. These are the high-yield variceal bleeding management pearls that Step 2 loves to test. For acute management, remember, resuscitation, Octreotide, antibiotics, and endoscopic band ligation. Transfuse conservatively with a hemoglobin goal of 7 to 8 to avoid worsening portal hypertension. For secondary prevention, the combination tested most frequently is a non-selective beta blocker like propranolol or nadolol plus repeat endoscopic band ligation until varices are eradicated. For refractory cases, the answer is transjugular intrahepatic portosystemic shunt. Make sure you know these protocols cold for test day. Now let's shift to lower gastrointestinal bleeding. A 75-year-old woman presents with sudden onset of painless bright red blood per rectum. She denies abdominal pain and her vital signs are stable. The bleeding stops spontaneously. What is the most likely diagnosis? Consider the key features before we discuss the answer. This case exemplifies a classic test pattern. The combination of elderly patient plus painless hematochezia plus self-limited bleeding is the textbook presentation for diverticular bleeding. Diverticulosis is the most common cause of massive lower gastrointestinal bleeding in older adults. Here's your test-taking strategy. Painless lower gastrointestinal bleeding in the elderly points to either diverticulosis or angiodysplasia. Painful lower gastrointestinal bleeding should make you think of ischemic colitis or inflammatory bowel disease. The correct answer is diverticulosis. Hemorrhoids would be a wrong answer because they typically cause blood on toilet paper, not massive bleeding. This next case tests a high-yield association. An 82-year-old man with chronic kidney disease and aortic stenosis presents with recurrent episodes of painless hematochezia. Previous colonoscopies showed arteriovenous malformations. What is the most likely diagnosis? Let's analyze this carefully. Recurrent bleeding plus known arteriovenous malformations equals angiodysplasia. But the board examiners have given us additional clues. The combination of angiodysplasia plus aortic stenosis is called Heide syndrome. And this is a favorite board question. Chronic kidney disease is also associated with angiodysplasia. For diagnosis, colonoscopy or capsule endoscopy can identify the lesions. Treatment involves endoscopic cauterization, and for refractory cases, angiography with embolization. The correct answer highlights Heide syndrome. Remember this association whenever you see aortic stenosis combined with gastrointestinal bleeding. Endoscopy timing is a key test concept that appears repeatedly. For upper gastrointestinal bleeding, perform esophago-gastroduodenoscopy within 24 hours in stable patients. For suspected variceal bleeding, perform within 12 hours. For massive or ongoing bleeding with hemodynamic instability, endoscopy is urgent after initial resuscitation. For lower gastrointestinal bleeding, colonoscopy is typically performed within 24 hours after bowel preparation once the patient is stabilized. Make sure you review the complete algorithms in your board resources. Let's wrap up with our final test-taking strategies. First, if the patient is hypotensive or tachycardic, always choose stabilization before diagnostic testing. This is the most commonly tested principle. Second, use pattern recognition. Melena means upper gastrointestinal bleeding. Painless hematochezia in the elderly means diverticulosis or angiodysplasia. And cirrhosis plus hematemesis means varices. Thank you so much for watching. If you found this helpful, please like and subscribe to our channel. For personalized tutoring and residency advising, visit us at roadmaptoresidency.com. Our expert tutors and residency advisors are ready to help you succeed. Good luck on your exam.